must also say I'm very grateful for the gentleman for turning off the football game because I'm sure I'd be able to compete. So tell us who's winning and losing. Anyway, so the objectives, going quickly, are just talk about the pathophysiology of OSA, the polysomnography for diagnostic purposes, some differences in infants compared to older children, and the role of the pediatric pulmonary sleep medicine. And the bottom line is the line from, it used to be a tagline for the Lung Association, is when you can't breathe, nothing else matters. And, you know, you do the magical surgical things. We try to go ahead and get the children through and put perioperative period and beyond to go ahead and grow to be healthy individuals. So the spectrum of sleep disordered breathing goes from less severe to more severe, and that being primary snoring, that is snoring without consequences of any obstruction. Obstructive sleep apnea, where there's intermittent airway obstruction and fragmented sleep, which alone has developmental problems. And then abnormal oxygenation and ventilation, which obviously has some cardiorespiratory implications later on. There's also complete obstructive hypoventilation, which is a combination of chronic OSA and hypercarbia. So I'm kind of bringing coals to Newcastle because I'm trying to go ahead and talk about the area that you all operate on a daily basis. I'm really going to focus on the increased upper airway collapsibility and resistance that we view from the medical, from the pulmonary side. So the normal anatomy, as you know, differs in infants. The trachea and larynx is superiorly placed in older children. The partitioning of the pharynx occurs to allow optimal suckling, but obligate nasal breathing when the fetal is an infant. And one gets problems when you have OSA from nasal obstruction, obviously. The mandible is nearly horizontal at birth, and that results also in a short ramus and a flexible temporomandibular ligament. And so there's propensity there for posterior displacement and obstruction in the normal child, as well as those with craniofacial abnormalities. The infant upper airway physiology is that very difficult. I've been doing this for 25 years, and I'm very surprised actually that even normal infants can seem to breathe with the physiology that I've come to deal with on a daily basis. The upper airway is very, very compliant in a young child. So that only a decrease of 2 centimeters in luminal pressure actually can result in a 50% reduction across sectional area of the neonatal airway. Rapid changes in the caliber of the airway then cause ventilatory instability, which causes obstructive cycling with intermittent obstruction and sometimes any good resolution. And that mean passive, and when I mean by passive, people under anesthesia, or children under anesthesia, the passive airway closing pressure in a 2-month-old is only 1/2 of 1 centimeter, whereas by 6 months, it takes, you need to have 6 centimeters of negative pressure to be able to close that negative closing pressure. So that what that means is that the normal passive viscoelastic closing pressure is near atmospheric in the neonate, and even in the normal neonate, it has a great risk for collapse. So ventilatory control in neonates, of course, is primarily that of CO2, with the central respiratory drive and also providing that airway tone. In fact, when one gives neonates 100% oxygen challenge, there actually is minute ventilation, a 38% decrease. If you did that for an adult, there's only a 6% decrease. And this is peripheral chemoreceptor driven. It contributes also then to the airway instability. Hypoxemia, on the other hand, is only a weak stimulus for arousal in infants. And prolonged hypoxemia, however, with obstructive sleep apnea, results in a decrease in lung volume, an increased metabolic work of breathing, difficult to get the kids to grow and to feed also, and then decrease in cardiac output also occurs. The infant chest also creates problems with the infant chest and neonatal chest essentially being a flail chest with a highly compliant rib cage causing paradoxical respiration. And this may persist actually up to 3 years of age during REM sleep. There's increased work of breathing at low lung volume. So what the child that the neonate has to do is to go ahead and maintain an end expiratory volume above what their standard passive volume, relaxation volume would be. And they do this by a combination of expiratory laryngeal closure, by post-inspiratory diaphragm activity, and by compensating by cutting tachypnea. But by 6 to 12 months, fortunately, as we get the kids through the neonatal and the early infant period, the chest compliance increases. So the symptoms, of course, are known in the frequent snoring. Only 10% of children with OSA have only 10% of snoring have OSA, but noisy breathing, gas, snorting noises, labored breathing, etc. But the 8.8 there is failure to thrive, the dysphagia that we deal with as the medical folks, which the dysphagia leads to episodic and chronic microaspiration, which for us can result in bronchiectatic changes and aspiration of fatty material, exogenous fats, then will lead to a very intense inflammatory response. And of course, the oropharyngeal flora that goes along with that can cause intermittent, if not chronic infection. So the history and physical is useful screening, but it has poor sensitivity and specificity. And alone, it can't tell us much about the severity of the apnea or the airway obstruction. The polysomnogram, we're talking not about home study, we're talking about overnight technician attended in the lab, the most accurate way to diagnose obstructive sleep apnea, and also the severity. You can throw in something for the pulmonologist and the sleep folks. The flexible radioscopy and bronchoscopy, doing a drug-induced sleep endoscopy, means the anatomic abnormality or level of collapse that leads into treatment planning. There's a lot of stuff with the cords, and that has to be taken into account as to how we're going to manage the child and how they feed. The pediatric polysomnography, many of you may know, but includes electroencephalogram, occulogram, and leg EMG, oxygen saturations and end-tidal CO2 with nasal and oral airflow being recorded by video camera and a microphone to help the person doing the interpretation actually correlate that on a second-to-second basis with the child's what's coming up on the polysomnogram tracing. And so this is a polysomnogram of normal breathing, which shows normal airflow here with a nice airflow tracing with no arousal and no evidence of oxyhemoglobin desaturation. This abnormal tracing, however, you can see here in this epoch, there's essentially no airflow, or there's mild, which is hypopnea, and there's significant arousals occurring as well as oxyhemoglobin desaturation. So what you should look for in a polysomnogram report? Clearly the AHI is important with mild 2 to 5 events per hour of sleep, moderate 5 to 10, and severe more than 10 per hour. But one also needs to look at the total time of the percent time of the study spent in a deep oxygen desaturation state as well as a hypercapnic state. That correlates with an arousal index and other pertinent findings such as the video and microphone tracings can be very, very helpful. There are no formal AHI norms, however, for children under 2 years of age. The Association of Sleep Medicine has debated this for a long time. So in neonates, we have to look at just not AHI, but also, as I said, this percent hypoxemia and hypercardia. One needs to consider that severity of the OSA, however, in relation to other therapeutic options. The natural history also of the craniofacial abnormality or what's going on in terms of what the natural history of that is, in terms of what implications that will have for future obstructive sleep apnea. The stepwise therapeutic approach then can certainly just go from positioning to supplemental oxygen to treatment of gastroesophageal reflux to high flow nasal cannula to CPAP, BiPAP, and then to surgical. And it's not meant to say that surgery is the last choice, but it depends on time. It's really a two-way street here. And certainly some of these modalities be able to successfully navigate various perioperative periods. And so what do we use? Most of you are familiar with the full face mask and the nasal face mask for infant BiPAP or CPAP, but more recently, if it's not precluded by the individual craniofacial defect, one can also implement high flow nasal cannula, which is moved with anywhere from 1 to 8 liters being the heated humidified circuit, now moving into a home setting over the last couple of years, and many infants are doing quite well with that to be able to go ahead and survive what otherwise would be very difficult airway obstruction. If people have chronic aspiration or kids do this, we have a multiple number of airway clearance modalities. These are volitional positive expiratory pressure devices where you're blowing against a resistance that actually stents the airway open by providing a back pressure and allowing secretions to move north from through what otherwise would be a collapsible airway. There's also high frequency chest wall oscillation, or the vernacular being the VAST. There's several VAST out. And also cough assist device, which is the only device out there that can provide both a positive pressure and then a negative expiratory pressure, trying to help with secretion clearance. So the drug-induced sleep endoscopy is very, very helpful, certainly in terms of looking at laryngomalacia, which I'm sure is common, but in children who have been intubated for a period of time, they frequently have some subglottic stenosis. But much of what we deal with is the tracheomalacia that results from a number of different issues, and we need to identify if there's lower airway abnormality as well and find a treatment plan that most often will involve some degree of positive pressure ventilatory support, either non-invasively or invasively. In summary, OSA is a multifactorial problem, particularly those in craniofacial abnormalities, prematurity, obesity, etc. There's a normal history and a wake exam are poor predictors. PSG is necessary for the diagnosis, I think, and it's also necessary many times to follow up on intervals after repair. Multiple diagnostic and treatment modalities are available, as we have discussed, and I would just throw something out there to include your pediatric pulmonary and sleep staff. I think it's been a very good collaboration here, and we're very excited to continue supporting the staff here.
Next up, we have Jeff Mabuda, who's going to be talking about the expanding indications for MDO and neonates.
Thank you. I have no disclosures, and I was asked to talk about the expanding indications for mandibular distraction osteogenesis. Let's see, how do I move this forward? Oh, you took it. As I said, I have no financial disclosures. You know, when you talk about these expanding indications, you know, as craniofacial surgeons, we want to distract everyone who's got a small mandible, who's got respiratory distress, and, you know, we feel it's an advanced sequence kid. But the reality is that you have to make these decisions based on evidence-based medicine, and it just can't be a congenital micrognathia that's present. You really, as was just stated, you have to look and determine, you know, what's mild, what's moderate, and where's your threshold. And there is no single one-point trigger point on the apnea-hypoponic index in these kids, but there's some confusion that exists, and I challenge you as craniofacial surgeons to stop and think about it. That the American Academy of Pediatrics, to minimize sudden infant death syndrome, says don't put kids prone. Don't do it. It's the American Nutrition Association, the GI Association, they all say don't put them prone unless there's bad reflux, but yet we say let's place the kids prone. And when you think about it, boy, that's got to be completely monitored because you know, you can't send them home and say, well, you know, place your child prone and totally ignore the sudden infant death syndrome. So from that, I started looking, you know, how can we provide some relevant positive predictive data to increasing the scope or increasing the utilization of distraction as compared to tracheostomy or tongue-lip adhesion. And clearly, the literature is pretty clear from an evidence-based medicine that the morbidity in tracheostomy is about 43%. Tongue-lip adhesion, although it doesn't have a high morbidity, it has a high requirement for secondary intervention, as high as 45% in some studies. The advantage of mandibular distraction, if you can include a lot of these patients, is that it addresses the underlying abnormality. I had the opportunity to review Bartlett's paper, which did an excellent review, just recently published in PRS. And they actually looked at and tried to do an evidence-based review from 1960 to 2017 to try to come up with some conclusions. And our CHLA experience was included in that, in those 67 studies. And essentially, what he found was that the distraction can prevent tracheostomy in 95% of the cases, that there was increased in oral feeds in 87% of the cases, and that the secondary surgical intervention was pretty low, about 4 to 6%. So the numbers were favorable in the mandibular distraction as it relieves the obstruction by correcting the anatomy. Now, he did find that there was a higher rate of long-term complications, as dental complications and facial nerve injuries, which we did not find in our study. Now, from an evidence-based standpoint, our studies correlate very well with Bartlett's paper, except for the fact that if you made it, we found if you made an inverted L osteotomy and made the incision about 1.5 centimeters below the inferior border of the mandible, that you could avoid some of the complications. But based on that, by taking those conclusions, we said, how do we expand it? And as was mentioned, we have a multidisciplinary team, and that's the only way to go by that, is to have your sleep physicians, and the ENT, looking in particular for, is there a central component to the obstruction? Is there a laryngospasm, laryngomalacia? Is there subglottic stenosis? Because those are high positive predictors of failure. I'll skip that one because we went through it. This is, from a surgeon standpoint, we tend to forget this hemoglobin dissociation curve. When a child's sagging at 90%, they're actually hypoventilating. Their PO2 is about 60. So the real question from you to ask your pulmonologists and to ask your pediatricians is that chronic hypoxemia with or without supplemental oxygen, what is it really doing to neurologic development? And we don't know, but what we do know is that hypoperfusion is really puts you at risk for end organ failure. So based on that, what we looked at is the comorbidities that were present in our patient population, and that was reflux, low birth weight, sequences syndrome, CNS anomalies, and we tried to say, what is the correlation between failure and the positive predictive failure? And so in order to delineate this quote-unquote expanded scope, what we said is, let's reverse engineer it. If we're going to really present something that's evidence-based that you can make a decision on, I can't tell you which ones to include that are going to be successful, but we do know which ones have led to failures. So these predictors for failures allows you then to hone in your expanded scope. So we published this recently, and what we looked at is, if the goal is to avoid tracheostomy, let's go ahead and look at all the cases that we've done retrospectively from 2008 to 2015. And we looked at the inclusion criteria, essentially were severe micrognathia with obstructive apnea and age less than 1 year of age in that time period. We split those two groups up into a respiratory failure and a respiratory distress. The respiratory failures, those patients are intubated, and they have clinical apparent obstruction that either was going to require a tracheostomy or an intubation. So they got intubated. The other group were the respiratory distress patients. So we looked at these two and ruled out the non-surgical candidates. So if the patients that were intubated had subglottic stenosis or severe central apnea or an obstructing mass, obviously they're not a surgical candidate. In the respiratory distress, they underwent sleep studies, and then we evaluated their comorbidities as well. And arguably they're a little different, but in general, the sleep studies are, really play an important role for us in that if the AHI is between 1.5 and 12, we really don't know how to classify that. Is that, what's the difference between 1.5 and 1.6? Nothing. So the crux of the matter is there's a gray zone between 5 and 10, and do those patients get distracted or do they not? So in summary, what we found is we had 82 patients that were included in the study. 25 of them were respiratory failure. In other words, they were intubated and they were surgical candidates. 57 of them were respiratory distress. Of those 82, there's a predominance of males at 47 of the 82 patients. Ruban sequence were included, syndromic patients, micrognathia, otherwise non-specified. 68 of those patients, or 82%, had CLUTs. So they underwent distraction for an average of 27.5 millimeters of distraction. Total activation time distracted for about 17 days and at about 1.7 millimeters per day. Consolidation of 4 months. So then we got sleep studies on them. And what we found was that in the respiratory distress group, and again, we took all comers, we found that the mean AHI preoperatively was 32. And the range was 5.4, so the low end on our AHI was 5.4. The postoperative sleep study, and that was about 2.3, 2.4 months afterwards, dropped to 5.8. And then approximately 3 years post-op, the AHI dropped to 2.4, with a range of 0 to approximately 17. So taking those data, and of those 82 patients, we had only a 91% success rate. And initially I told you our data was similar to Bartlett's. Well, his was over 95%. So clearly we had some failures, but we were all inclusive. So what were those failures and how do we determine the positive predictive value for those failures. The failures were 2 deaths and 5 tracheostomies. So let's talk about the deaths. Patient number 1 had a positive history of central hypotonia in association with the sleep apnea. GERD. That patient was extubated and essentially post-op day 69 was found apneic and pulseless. Patient number 2 had Cornelia de Lange syndrome and multiple other comorbidities, including ASD, persistent left superior vena cava syndrome, laryngomalacia, GERD, polycystic kidney disease. That patient went into cardiac arrest after he was extubated, after he was distracted. So doing a predictive probability analysis, what we were able to determine with a reasonable degree of certainty is that if patients have severe CNS anomalies, the positive or the predicted probability is a 45% chance of failure, as opposed to without CNS anomalies where it drops down to 2.7. And that p-value is obviously significant. It's at 0.02, giving us a 45% positive predicted value. So CNS anomalies, the takeaway is that those are relevant to mandibular distraction, but it's not just any CNS anomalies. What if you're just on the spectrum of autism that's mild? Well, that doesn't really count. The ones that we found that really contributed to this was central hypotonia, agenesis of the corpus callosum, encephalopathy, essentially loss of the white matter, and severe seizure disorders in the setting of a syndrome. The other really important data point that we were able to delineate was that the preoperative positive predictive values of total